Okay, let's dive right in. If you're prepping for your anesthesia exams, you know pain management for thoracic surgery is a massive topic. So we're going to break it all down in this explainer, a really high-yield guide to regional analgesia based on the absolute latest research. And why is this so important? Well, look at this number. A staggering 57% of patients still have chronic pain 3 months after a thoracotomy. That's huge. This isn't just about feeling better in the short term, it's about preventing a lifetime of pain. And our best weapon against that is excellent acute pain control. So here's our game plan. We'll start with why this is such a challenge. Then we'll get into the nitty-gritty of the anatomy. We'll compare the classic blocks against the newer fascial plane blocks. And then, most importantly, we'll figure out how to choose the right technique. And we'll finish up with the key points you've got to know for your exam. Right, so first things first, the problem itself. Thoracotomy is without a doubt one of the most painful surgeries a patient can go through. Understanding exactly why and what happens when we don't get the pain control right is absolutely fundamental. Now, here's something that might surprise you. You'd think that the minimally invasive approach, VATS, would basically solve the pain problem, right? Well, it definitely helps with acute pain, but, and this is the kicker, the evidence shows it doesn't really change the risk of developing chronic pain. So no matter how it's done, we're facing a major pain management challenge. And the stakes couldn't be higher. You know, poor pain control is so much more than a comfort issue. It triggers this whole cascade of serious problems. Patients can't move, they can't take deep breaths, they can't cough properly. That leads directly to things like chest infections and blood clots. And of course, it's the #1 driver of that chronic post-thoracotomy pain syndrome we're trying so hard to avoid. Okay, so to block the pain, we first have to understand where it's coming from. The nerve supply to the chest wall is pretty complex, but if you can nail down the key targets, you're well on your way to picking the right block. This diagram really shows you what we're up against. Pain signals are coming from all over the place. You've got the intercostal nerves, which handle the incision pain, but you've also got the dorsal rami covering the back muscles and the sympathetic trump carrying that deep, visceral pain from inside the chest. A truly effective block has to hit all of these targets. So here's the bottom line. Our goal with any of these techniques is to put up a complete wall. We need to block both the somatic fibers, that's the body wall, and the visceral fibers. We want to stop those pain signals dead in their tracks before they even have a chance to get to the brain. All right, let's talk solutions. We'll start with the two big ones, the techniques that have been the gold standard for a long, long time. The thoracic epidural, or TEA, and the paravertebral block, or PVB. And right away, we hit a real game changer. For years, the epidural was king, but now study after study has shown that the paravertebral block is just as good at controlling pain, but with way fewer side effects. This is a massive shift in clinical practice. This table just lays it all out, plain and simple. Efficacy, they're both excellent, no question. But then you look at the side effects and risks. The epidural brings more low blood pressure, more nausea, more itching, more urinary retention. And the big one, a higher risk of a devastating epidural hematoma. The paravertebral block is just a safer option. So if you only remember one thing from this section for your exam, make it this. The official prospect guidelines now recommend the paravertebral block over the thoracic epidural for open thoracotomy. And why? Because it works just as well for pain, but it's significantly safer for the patient. End of story. But wait, the story's not over. In the age of ultrasound, we've got a whole new category of blocks that have come on the scene, fascial plane blocks. These are often easier to do and, as we're about to see, they bring an even better safety profile to the table. And here they are. On the left, that's your classic view for an erector spinae plane block, the ESPB. See those flat top hills? That's the transverse processes. On the right, that's the serratus anterior plane block, or SAPB for the side of the chest wall. These are the images you have to get burned into your mind. The ESP block is actually pretty clever. You inject into this fascial plane way out back, and the local anesthetic just spreads forward all on its own into the paravertebral space. That's why people call it a paravertebral block by proxy. You're getting a similar result, but with a much more superficial and safer injection. And this right here is their killer feature. Because the needle and the local anesthetic are nowhere near the spine or major blood vessels, these are considered superficial blocks. And what does that mean? It means they can be an option for patients on blood thinners, patients where a deep block like an epidural would be an absolute no-go. That's a huge deal. Okay, so we've looked at all the options. Now for the million-dollar question. How do you choose?
Well, thankfully, the Prospect guidelines give us some really clear, evidence-based roadmaps to follow, depending on the surgery.
For a minimally invasive VATS procedure, the recommendation is crystal clear. First line is a paravertebral or an erector spine plane block. And ideally, you're going to place a catheter so you can run an infusion afterward. SAPB is your backup plan. But look at what's at the bottom. Avoid routine use of thoracic epidurals. For VATS, the risks just aren't worth the benefits. Now, for a big open thoracotomy, the algorithm is a little different. The preferred choice is still the paravertebral block. But here, the thoracic epidural is still a strong alternative, often with a little opioid mixed in to help with that deep visceral pain. And if both of those deep blocks are off the table for some reason, then our safer options, like the ESPB, are the way to go.
All right, let's bring it all home. We're going to consolidate everything into the absolute must-know high-yield points for your revision. This is the stuff you've got to have down cold.
So let's lock this in. 1. Thoracotomy pain is complex. It comes from everywhere. 2. For open surgery, paravertebral block is now preferred over the epidural because it's just as good and much safer. 3. For VATS, it's PVB and ESPB first line. Epidurals should be avoided. 4. Don't forget catheters. They're crucial for extending pain relief. And finally, number 5, remember that these blocks are just one part of a bigger multimodal pain plan. And I'll leave you with a question to think about for your own career. The evidence for these newer, safer fascial plane blocks is growing every day. So the challenge for all of us is to figure out how can we use these techniques to make things better and safer for our patients. What's your approach going to be? Everything we've talked about here was based on an excellent 2023 review article by Mehta and colleagues in BJA Education. If you really want to dive deep, I highly recommend you look it up. It is definitely one for the revision folder.